as some of you may know, only really recently joined the faculty at Yale. He is a professor of radiology and biomedical imaging and vice chair for clinical research in the Department of Radiology and Biomedical Imaging at the School of Medicine. He received his doctorate at the University of Pittsburgh and did his residency training at SUNY Stony Brook, and then additional fellowship in vascular and interventional radiology at University of Texas, MD Anderson. And David is really an international leader in advancing the work of interventional radiology in impacting both clinical care and clinical research in complex oncology problems. And we're really very fortunate to have recruited him to Department of Radiology in the Cancer Center, and he's going to share some of his ongoing work, particularly within the liver. So David, thank you.
Okay, thanks, Charlie. I really appreciate the great introduction, and I'm really honored to be here. This may be a little bit different than what you normally see as a speaker for grand rounds here, because this is a lot of different types of techniques. This is not technically to cure cancer specifically, but it's to help get, in large way, patients to surgery. So these are my disclosures, none of which are actually relevant to this talk. So I had gotten interested in liver regeneration back when I was at MD Anderson. This was like in the year 2000 when I had to present the complication of the procedure. But as you can see from these two cases, one with bilobar colorectal metastases and another with a huge HCC with multiple satellite nodules, we can actually take patients using liver regeneration strategies to get these patients either to surgery or to even treat, actually to cure them. And what I wanted to discuss today was methods for improving safety or even obviating the need for major liver resection. Unfortunately, due to the time constraints, I do have some work I would like to show at some point on cellular therapy for treating cirrhosis. We do have an animal model for cirrhosis that we do want to place a tumor in and ultimately do some kinds of therapies for this, but at this time, I don't really think it's possible. So as you're all aware, there have been tremendous advances in hepatobiliary surgical techniques such that death is now considered rare. However, complications such as fluid retention, cholestasis, and impaired synthetic function still contribute to prolonged recovery times and extended hospital stays. This is also true in the setting of cirrhosis, where you can see patients that just have their right liver removed. Patients can have up to a 60% mortality. So in patients that have an HCC that need major surgery, you can see that there's a need to help these patients get their surgery. Otherwise, they obviously would die without it. One of the issues with having patients undergo surgery is the size of the remnant liver. And as you can see from this study from Paris, is that there's a direct correlation between the size of the remnant liver and those that have complications. Now, this is not to say the overall type of complication, but it's to show that the smaller the liver, the higher likelihood you are of having complications. And if you do know in advance that you may have a complication, chances are these patients will not undergo their surgery. Unfortunately, at this time, there's still no limit to how small a liver remnant you can have. Now, previous studies have suggested that in order to reduce the morbidity of hepatic resection, about 20% of the liver must remain in patients that have what you call normal underlying liver. That's, for example, patients that have colorectal liver metastases, never had chemotherapy, right to resection, 20%. Injured liver, you need about 30%. And we mean by that is patients that have had a lot of chemotherapy, have steatohepatitis, et cetera, and 40% in those patients that do have cirrhosis. That's actually with a normal underlying liver function. If you have abnormal liver function, you actually need about 60%, or you may not get surgery at all. So what we're going to talk about briefly today is what I call preoperative strategies using liver regeneration with alphabet soup, okay? So portal vein embolization is PVE, radiation lobectomy we'll get into is RL, associating liver partition and portal vein ligation, which is a surgical procedure, is called ALPS, and then we're going to discuss later liver venous deprivation, which we will be having a clinical trial here starting in the near future. So in terms of historical perspectives, we all know about Prometheus, who was a Greek titan, And what he did was he gave fire to the humans, ultimately helping them progress. And Zeus, who I guess was the head of all the Greek gods, was very upset about this. So he had a plan of giving him a punishment, which was pecking out his liver every evening. And ultimately, the liver grew back, and this just got repeated and repeated and repeated, which sounds like a very awful existence. However, we really didn't know that the liver regenerated experimentally until 1920. And this was a study from Rue and Larimore, who found that portal vein ligation in rabbits, if you ligate what's called the ipsilateral side, that means the side that you actually ligated, you get atrophy of that side, and then you get hypertrophy or enlargement of the contralateral side, that's the side that you did not ligate. And this was also found to be shown in bile duct occlusion, where that was shown in the 1950s. In 1986, Kinoshita published on doing PVE before HCC resection. The fact is that embolization of arterial embolization is not very effective against portal vein tumor thrombus. So they thought that if they could embolize the portal vein side, that they could try to stop the growth of the portal vein tumor thrombus. And as we know, it's portal vein tumor thrombus that actually results in what patient's prognosis is in terms of liver cancer. And then it was the seminal work from Mikuchi at the University of Tokyo that first performed portal vein embolization solely to initiate contralateral hypertrophy in 13 patients with Klatskin tumor. What he found, or the group found, is that PVE is safe, does not complicate the surgical resection, and then liver failure is actually less common after this procedure. Now, in terms of physiology, the atrophy-hypertrophy complex is actually still, to this day, poorly understood. We know that there are essential components. We know that there's the ability to de-differentiate and clonally expand the liver cells, not just the cell mass, but also the cell number, and that there's multiple stimuli to hypertrophy the liver. We also know that hepatocyte growth factor is the strongest mitogenic factor, and it's released from hepatocytes really soon after hepatocellular injury. And gene induction can actually occur within the first 30 minutes and can last for quite a while, but the peak of liver regeneration is within 7 days, and then typically it returns to baseline within 2 weeks. And we also know that patients that are diabetic, because insulin is a cofactor with hepatocyte growth factor, that those patients that have diabetes have less regenerative capacity. We also know that because patients with HCC who have cirrhosis have very scarred livers and less flow through the liver, they actually have reduced regenerative capacity. So just for this purpose of this talk, I wanted to go over some important terminology. Future liver remnant is what we're going to talk about a lot, and that's anticipated liver parenchyma remaining in situ after resection. We already talked about how much you need. The degree of hypertrophy is a dynamic measure of liver regeneration, such that if we look at the post-FLR and we subtract the pre-FLR, we actually have what's called the degree of hypertrophy, and that lets us know how well the liver regenerated. And then kinetic growth rate is actually the degree of hypertrophy per week. And we know based on some numbers or some data that there's certain amounts of degree of hypertrophy and kinetic growth rate that will either allow patients to have surgery, or we will say maybe this patient shouldn't have surgery because their liver is not regenerating sufficiently. So what is portal vein embolization? Well, this is a strategy to redirect portal blood flow to the future liver remnant. And what we can do here is initiate hypertrophy of the non-embolized segments. And ultimately, the goal is to reduce perioperative complications and increase potential surgical candidates who have what we call marginal anticipated future liver remnant volumes. The goal is not necessarily to get better outcomes than patients that did not require PVE. However, the goal is really to get the patients to surgery so they have similar outcomes. And until recently, the consensus was that PVE is the standard of care for safe and effective generation of FLR hypertrophy preoperatively worldwide. So we know from some clinical studies that the lobar function does shift from the embolized to the non-embolized lobe after PVE, and we see some nuclear medicine studies showing that. We also know in patients that have, for example, Klatskin tumors where they have bilateral or bilobar biliary drains, that those patients that have PVE, the amount of bile that's produced actually increases in the hypertrophy liver and decreases in the atrophy liver. And we also know from study at MD Anderson that you have less alterations in liver function tests after resection following PVE. In terms of impact, there's been 37 publications that were included in a meta-analysis of over 1,000 patients, and what they found was that the morbidity rate for these procedures is very, very low. There's a 0% mortality, although I'm not sure how accurate that is, and that most patients, about 85%, actually do undergo their planned hepatectomy. What happened there? Unfortunately, there are some patients that either progress during the waiting period or don't get sufficient regeneration such that they actually don't become surgical candidates. Just to go briefly over some techniques, there's a whole host of techniques that have been described. We're just going to talk about a couple briefly, but this just shows that there's standalone and combination therapies. The original technique that was described by Makuchi was what's called the transileocolic intraoperative vein approach, where they just cannulated the ileocolic vein, threaded a catheter under basic fluoroscopy up into the portal vein, and then injected their material and ultimately got portal vein embolization. In the 90s, the first percutaneous approach was called the Transhepatic Contralateral, where you go directly into the liver from outside percutaneously. And as you can see, one of the problems is that at the bottom here is that if you do get an injury to the liver remnant, because you are going in through the liver remnant, this patient will no longer be a surgical candidate, because if you have to embolize or treat the liver that's bleeding, you kind of hose the patient, okay? So over the course of the last 2 decades, we've been very big supporters of actually accessing the liver transhepatically through the liver that's going to be taken out. And so that avoids FLR injury, and you can see here there's a pseudoaneurysm that ultimately is resected at the time of surgery, and it's no big deal. This is actually a very multidisciplinary approach. Patients are seen by medical oncologists, hepatologists, surgeons, and interventional and radiologists and interventional radiologists. This is not a very, I wouldn't say it's a very glamorous type of procedure. It's not arterial embolization. It's not ablation where you're doing the definitive therapy, but you're really working as part of a multidisciplinary team. We need to look at the patient's underlying liver disease, whether they have a reduced regenerative capacity, and if you're unclear, you can do a biopsy of the non-tumorous liver. We look at patient size with the understanding that larger patients require larger liver remnants, such that liver standardization is critical. We look at the extent of hepatic and associated non-hepatic surgery, as well as what we talked about earlier, some of the other factors, such as whether patients have had diabetes or preoperative chemotherapy. This is just how we measure the liver. We only care about really the size of the liver remaining, and I'll get to why that's important, because if we look at this linear regression equation, if you take the part of the liver that atrophies and the part of the liver that hypertrophies, you may get a denominator that changes over time, and ultimately you can get what looks like hypertrophy, and actually you got none, and the patients after their PVE, if they didn't grow, they have actually been found to die after procedures, after the major surgery. So we use this very standardized formula where you see here, you can see that the left lateral liver got much bigger after 4 weeks. FLR increased from 17 to 30%. Degree of hypertrophy was 13%, and the kinetic growth rate, which is again divided by the weeks, is 3.25%. In terms of absolute contraindications, anything that would keep a patient from surgery is absolute, such as overt clinical portal hypertension. We also know that extensive portal vein invasion precludes safe catheter manipulation and embolic delivery, as well as those that have complete lobar occlusion already have their portal vein diverted, and that's how we know in a lot of cases that patients have cirrhosis, for example, when their left liver grows huge. In the old days, we used to have some of these used to be considered absolute contraindications, such as extrahepatic metastatic disease and tumor invading the FLR or involving the FLR. However, nowadays, with much more aggressive surgery, we can see that these may not be, they're actually more now considered relative. There's been only one study in the setting, one prospective trial looking at the benefit of PVE in the setting of right hepatectomy in liver disease. You can see that based on all the parameters here, except death, that this procedure does significantly improve postoperative course. This is one example, 56-year-old male with HCC of hepatitis B and C. We measured the FLR to be 33%, which is too small, as we said. The patient had excellent growth. So this patient was considered a candidate for right hepatectomy. This is what the liver looks like intraoperatively, where you see the left liver is huge and has very obtuse margins, where the part that was embolized is very dusky in appearance and has very sharp acute angles. So this patient ultimately had the surgery, uneventful hospital course, however, did develop recurrence at 5 years and then underwent a successful transplant. This was a study that we did during my days at MD Anderson, where we looked at patients with HCC and underlying liver disease, and it's only in those patients that did not have the PVE that did ultimately end up with dying from the surgery. You can see here that the 18% death rate, not good. And then if we look at HCC in the setting of chronic liver disease for survival, you can see that there's very similar 5-year overall survivals in those that had PVE versus those that didn't. Importantly, in those patients that had PVE, had they not had PVE, they would have probably undergone chemoembolization or some other kind of procedure and only had a 20 to 30% 3-year overall survival. So you can see just by doing this procedure, getting patients to surgery, you can actually improve their survival. Something that I discussed not too long ago, but seemed to have gotten a lot of attention, was something that we do called sequential arterial and portal embolization. This is actually separated by 3 to 4 weeks. And the rationale here is that the capacity for liver regeneration after PVE and resection may be impaired. So, and that most HCCs are hypervascular. So if you do portal embolization, you'll get arterialization of the liver, and the tumors will be inspired to grow and ultimately could take a patient out of resectability. And then we also know that HCC and cirrhosis has arterial portal shunts that could actually limit the regeneration after these types of procedures. So this is just a case that I showed, such that TACE is followed by PVE now should be considered as the standard of care for patients with chronic liver disease with HCC that before hepatectomy. This was just a study from Paris showing the benefit of PVE and TACE combined versus PVE alone. You get much better hypertrophy. You get an 83% complete pathologic response. And the goal here is that you do really need to wait 3 weeks after the TACE to reduce the risk of hepatic necrosis that could occur by combining the arterial and portal embolizations. And this was just a complementary study from Korea that showed very similar findings. They also found that you get significantly better overall and disease-free survival. This was one of the cases that I showed very early in the talk, how we can basically take a patient that's completely out of resectability, and by doing arterial and portal embolization, and then actually never even doing the surgery, could lead to a very long survival. Now, I'm not saying this would be done in every patient, and the goal ultimately was to see if this patient could get surgery, but ultimately, in this case, we did not do surgery, and maybe this is a way for definitive therapy. In terms of colorectal liver metastases, there's also near equivalence of 5-year overall survival. As I had mentioned a little earlier, there is potential for, or is concern for this procedure causing increase of tumor progression. And this just shows a propensity score matching where that was shown not to occur, okay? This was the case that I also showed in the beginning. We would all say this patient is completely outside the realm of any kind of resectability. Multiple tumors throughout the entire liver. This patient got chemotherapy. The tumors got much smaller. We then did what's called stage 1 hepatectomy, where they removed whatever would be a tumor that would be in the liver remnant. This patient had a 16%, and as we said, the patient really needs about 20% to get surgery. We did the PVE, and the patient ultimately had successful surgery. This is a study that we did at MD Anderson that shows group 1, which is those patients that did not have tumor in their liver remnant, and compared it to those that had a need for a 2-stage hepatectomy. And what we found was at 3 years that by doing this complex approach of 2-stage hepatectomy, we were able to get near equivalent 1- and 3-year survivals. And then this was a study that we published in JCO that showed in select patients that did make it to the 2nd stage, we were able to get a 60% 5-year survival. And again, these are very select patients, so I'm not saying that these are all comers, but those that did make it to the 2nd stage. So there is a need for alternative approaches. As I mentioned, there are some patients that drop out or have, based on the lack of sufficient FLR hypertrophy or tumor progression. And one of the things that I'm sure you're interested in here is whether or not you can maintain patients on chemotherapy during the waiting period. And the fact is that in the beginning of all this work, it was thought that the chemotherapy would in fact damage the liver and impact the regeneration. However, it's now been shown that if you do chemotherapy before and during the waiting period after the portal vein embolization, that there still is sufficient liver regeneration. Some of the things that have been worked on is that if a patient does not do well after PVE in terms of regeneration, you can then embolize the hepatic vein in addition to the portal vein. Okay, that is that actually causes what you would consider a Budd-Chiari approach, and ultimately you get a very big liver remnant if you embolize the portal vein followed by the hepatic vein. There's also been interest in hematopoietic stem cells. So you would do the portal vein embolization, then you would infuse stem cells into the portal vein, and it's been shown that you get much better hypertrophy. You get the addition of these stem cells that then turn into hepatocytes, and you get much better outcomes. There's also been interest in what's called radiation lobectomy, where you do Y90 radioembolization to the liver in an event to treat the tumors. And it's been shown that over the course of time, the liver that was treated with the Y90 actually does get fibrotic, and that causes the other side to hypertrophy. Problem is that you don't really know, based on the degree of hypertrophy and the kinetic growth rates, if the patient can ever have their surgery. However, some of the proponents, which includes Northwestern University, does think that this is like a test of time approach, that you can see how the patient's going to do if they get new tumors elsewhere in the other lobe. A couple of the last things. There's been interest in a surgical technique to kind of completely take out interventional radiology. This is a procedure that's done in 2 surgeries where they're trying to get massive hypertrophy very quickly so the patients don't fall out of surgical criteria. What they do is they do the liver remnant surgery, and then during that time, they completely devascularize segment 4, which is the medial left lobe of the liver. And then they ligate the right portal vein, and then you bring the patient back 7 to 10 days later, and you ultimately have a massive hypertrophy, but the patient has it's a very, very morbid procedure. So this was just looking at some data from MD Anderson, comparing it to the ALPS procedure, and you can see that the amount of hypertrophy and the time to get that hypertrophy is very, very rapid. However, they do have very, very high increased numbers of complications and even death. What's interesting here is that the liver may grow massively. However, if you look at electron microscopy, for example, it turns out that the cells, despite the fact that they're huge, actually are immature and don't function like a normal liver cell. So even though you get this massive hypertrophy and we're looking at the volumes, the functional capacity of those areas may not be that great. And this was just a meta-analysis just showing that ALPS, the kinetic growth rate, does grow in fact faster. However, there is much more overall morbidity and mortality. So while ALPS may be suitable, you really need to consider the morbidity and mortality before doing these complex surgeries. Lastly, I talked about liver venous deprivation. This is based on the hepatic vein embolization and the portal vein embolization that we had just discussed. The goal here was to shorten the time between the 2 procedures to get patients to surgery. It has been shown that this is now a feasible approach, and that if you look at this part here where you place, you do portal vein embolization and then you place plugs and other material into the right hepatic and middle hepatic veins, you can get almost to the point of the hypertrophy that you would get with the ALPS procedure. But it has been shown already that it may be that the cells function better because it does take a little bit longer to do. One thing I wanted to show is that there will be a clinical trial that we're doing here at Yale. I'm going to be the PI with Charles Cha from surgery as the co-PI. This is called Dragon 1 and Dragon 2. Dragon 1 is where we're just doing a feasibility study. And then Dragon 2 is taking the liver venous deprivation and comparing it to portal vein embolization alone. So that's something that's going to be starting here probably in January. So in conclusion, I hope to have shown very, very quickly that liver regeneration is critical to managing patients with primary and metastatic liver cancer, and that there are numerous strategies that exist to regenerate liver via percutaneous and surgical means. I do have some very exciting stuff that I think maybe some other venue I can talk about, which has to do with some cellular therapies and other methods in an animal model to do this. But for the purpose here, I think that I wanted to get you all interested in the fact that interventional radiology does more than ablations, biopsies, other embolizations, and that I think that there's a lot of opportunity for collaboration and growth. So with that, I think I'll stop here. Thank you for your attention.
David, thank you. Just before we open it up, so when looking at these approaches like PVE, are there studies or efforts where you could introduce additionally pharmacologic interventions?
Absolutely.
That could improve efficacy, and where is that currently?
Well, I mean, there has been interest in infusing hepatocyte growth factor, for example, directly into the liver. There's been other agents that have been used. There's even been what's called, I took out a lot of this stuff for the purpose of the time, but there's even been interest in what's called reversible PVE. So one of the problems with PVE has been that it's a very definitive therapy. So if the patient doesn't get resected, can you still give a transarterial therapy? So there's been interest in what's called reversible PVE, which has been published in the Journal of Hepatology. And then because most of the regeneration occurs within the 7 to 14-day window, you can even repeat that. So there's been interest in that. But in terms of pharmacologics, the answer is absolutely, that there is interest, but it's also about some of the problems are that if you do it in animals, they're typically always in normal liver and they don't have tumors in them. So you don't really want to do this in the absence of a clinical trial, and just getting patients into these clinical trials has been kind of difficult. As I said, there's been only one clinical trial that showed the benefit of portal vein embolization compared to no portal vein embolization. And the reason why that is that it's an ethical dilemma for a surgeon to do a procedure on a patient or do a surgery on a patient when they figured they could have had a PVE, but then because of the trial didn't, and then they died. So, you know, but the answer is yes.
Chemotherapy during the waiting period.
Mm-hmm.
Does that affect the functionality of the regenerated liver, regenerated cells? Is there work on that front? I know there's with the regeneration clearly static, but is the quality of the cells or
Well, that's a little bit unclear. There is, as you know, some chemotherapies that damage the liver parenchyma more than others, like oxaliplatin, for example. There's also been studies that have shown that if you give more than, or I should say, if you give less than 3 months of chemotherapy, the patients actually do better after surgery than if they have cycles that go beyond the 3 months. So that was a study that was published at MD Anderson by my former group. So the answer to that is probably yes, but I don't know if there's, you know, there has to be, I'm sure, a basis for that.
David, thank you for that. It was really instructive.